Healthcare is heading for what appear to be some difficult times as federal policy changes and demographics shift. We'll hear from a panel of Twin Cities health leaders on what they see ahead and how they're preparing. This is Hospital Matters, a podcast from the Minnesota Hospital Association. We're having conversations about issues impacting hospitals, health systems, and patient care in Minnesota. I'm Tim Nelson. In this episode, we'll have an excerpt from the Minneapolis-St. Paul Business Journal's Healthcare Update Forum, recorded January 15th in St. Paul. The speakers start off with Lisa Erickson, CEO at Medica, then Dr. Rahul Koranne, CEO at the Minnesota Hospital Association, Lisa Shannon, CEO at Allina Health, followed by Dr. Emily Chapman, CEO at Children's Minnesota, and finally, Todd Archbold, CEO at PrairieCare. Here's moderator Dirk DeYoung, editor-in-chief at the Minneapolis-St. Paul Business Journal.
And what are the biggest challenges and opportunities facing your organization in general at the moment?
Well, I'm guessing there'll be a lot of commonalities in the biggest challenges because we're all challenged by both pressure around costs, medical cost trend, as well as disruption in the industry. And that's been something that has been on our mind significantly. We've seen medical cost trends continue to go up. This year was a year of unprecedented disruption in the market. We had Medicare members, almost 200,000 Medicare members that needed to find new plans this fall. We have significant uncertainty in the individual market as we, at this point, expect the subsidies to be sunset, but that's still up in the air and it's creating a lot of uncertainty for members. And we have uncertainty in the future as we think about where some of the legislation is going related to Medicaid. So that's the biggest challenge, I think, in the industry, and especially when, what we would like to focus on is how do we improve the healthcare experience and improve outcomes for members and patients. But the immediate need is, how do we ensure that we're serving members through that disruption, through that uncertainty. And so that's really the biggest challenge for us.
Rahul?
Can I say everything? At the end of the day, I would say ensuring that everyone has care that they need and everyone has access to the care that they need at the right time, at the right place, with the right care team, is challenging right now because there's so many headwinds that are coming at the hospitals and health systems across the state, be it rural, be it metro, everybody. Almost 40+% of the hospitals last year lost money. And for business leaders like you have to really understand what is happening there to put that comment in perspective with the worsening affordability. So how is it possible that hospitals are losing money? Well, it's possible. Our data clearly shows it, and the trends are going in the wrong direction. So the workforce challenges continue, and I think we'll talk more about that. But because we are a service-oriented sector, at the end of the day, AI in a couple of years may get there. But right now, what you need when you really need us is you need, one of our nurses, you need our physicians, you need our social workers, you need our care managers, you need our volunteers and nursing assistants, that care team to take care of you. And in order to support them, you need the funds, which are running short, and services are closing, and have been for the last year to two, and the services are closing at a much faster rate, not because we want to, but because the hospitals are being forced to close them, and because there's workforce shortages. At the end of the day, that nurse, that physician, that nursing assistant, that pharmacist that surrounds you when you need care at the right time is becoming very difficult. So that's the biggest challenge. And that's a human need at the bottom of the pyramid. It's right there with safety. When you have a heart attack or you fall and break your hip, you need care now. And that's becoming really difficult. So that's an essential challenge of our sector that's getting worse.
All right, I assume we're going down the row. So I'd say a couple things. We talk a lot with our team about the reality that two truths that are opposite are happening at the same time. On one hand, I talked about technology, clinical advancements. Dr. Chapman talked about some of the new clinical advancements for our patients. We're all super excited about that. On the other hand, we have a business model that actually doesn't work. The economics in healthcare do not work. I've been doing this for over 30 years. I'm a dietitian by training. I really believe in how we can make our communities more healthy. The most affordable care is care that is not needed, care that is prevented, disease that's detected early, ways that we can really work to enhance the health, which I truly believe healthcare is a human right. And how do we take these precious resources and really orient them in that direction? That's not how we're designed. That's not the business model in the United States. And in Minnesota, we're facing a math problem. Mm-hmm. We have some of the lowest government reimbursement in the country against some of the highest labor cost pressures, and I want our staff paid well. They work so hard, and we want to take care of them, but this math problem plays out for employers. We're a really big employer ourselves. We struggle with healthcare costs too. And so we've got this it really is structurally, we have a structural problem with a business model that's designed in a manner that's not sustainable.
The number of things that I'm worried about is just. I'll tell you this morning in particular, what's most concerning to me is our next generation. I think we are in a situation, I mentioned, we are capable of so much. And we're capable of so much in healthcare and healthcare supporting a healthy community so that we can thrive. We are not on a path to achieve that. There are decisions we're making now, disinvestments that we're making now that are setting us on that journey. At Children's Minnesota, not-for-profit organization, we have children who we deliver care to. We also are the voice of children. We use our kid expertise to proudly advance child health. I can tell you today, we are not advancing child health. We are doing everything we can to try to protect child health against all of the things that are eroding it right now. Some of that is recent daily events. It is children in our neonatal intensive care units without parents because their parents don't feel they can safely be with their newborn sick child. It is children who are in our intensive care unit because 4 or 5 days ago, they didn't seek the health care they needed. And they are now in a state where we cannot reverse the damage that was done. So that's just what's happening right now. And then the larger picture, our pulling back funding for healthcare. I think one thing people don't understand is we don't just, in that process, remove healthcare for some, for certain populations, for other populations. It is destabilizing your healthcare. The children that I take care of, I can only take care of if we are smart about this. So I think that we have a generation right now that is going to be growing up in the context of intense trauma. And we're going to need to be prepared to take care of them, all of them, every color, every nationality, every religion, every perspective, every background. And in order to do that, we have got to make sure that we are stabilizing the systems that need to be in place to do that, and I feel that we're not.
Oofda. This is poignant commentary, and it's all on point, and you know, you're going to hear a lot of themes today, and we are all truly partners in this mission, and you know, we're pointing out a lot of the challenges which we're here to turn into opportunities. However, I feel like it's on me to uplift the mood right now. I'll get there. Yeah, but I will start by saying, you know, yes, as my colleagues up here have also stated, we're facing a lot of headwinds, and through my lens, our organization is facing some of the most significant financial headwinds that we've ever seen. We're working on the tightest budget we've ever had this year operationally. The reimbursement landscape has become so volatile with shifts in the payer mix locally, changes locally in state government and federal government. I recall a couple years ago at this panel talking about the hardships of the Medicaid system reimbursing so poorly. Typically about 60 to 70% of the actual cost of care, which is, you know, then cross-subsidized by more commercial plans, and it's just the way we're built. And as Lisa pointed out, this isn't a business model. This isn't working for us. And now I'm here today not to gripe about that low reimbursement, but to hope that we can still get it. There are so many changes happening that the uncertainty has really put the pinch and the pressure on how we operate. And these are headwinds that we're all facing, again, as a team, as partners up here. From the mental health lens, the thing that I will talk about every year, one of the challenges and one of the opportunities that we are adamant in addressing is the access issue. And this is across all of healthcare, but particularly in mental health care, making sure that we have an awareness, making sure that we have open doors, open roads, open lines to us when people need us. Sue Abderhold, our former executive director of NAMI Minnesota, said it best: our mental health care system is not broken, we've never built it. And if there's any homework I can give you all today, it's familiarize yourself with mental health services in your community, ranging from 988 suicide prevention hotline, which you can call, you can text, to the local providers in your community. There are great resources around us. Get ready, know where they are, know how to access them for you, for your friends, for your family. Access is there, and as a provider group, we need to make sure it's accessible through coverages, through accessibility simply by breaking down structural barriers and more. This is something every year we come out of the gates wanting to improve upon, and we're getting there, but we have a long ways to go.
You talked a lot about headwinds, and let's dig into one of them, and that is federal health care funding. And we'll address this to Emily. She can start. What are you watching on the federal level as policy shifts and funding shifts, and what do you hope happens or fear?
Let's see. When it comes to watching things going on the federal level, it's a full-time job to keep an eye on that because things are shifting so quickly. So I think one of the things we're all struggling with is that there is such lack of certainty. What is announced one day, a week later, turns out to have a condition associated with it that excludes our participation, for instance, or is upended and shifted. So it's extraordinarily difficult to plan ahead. We put together a budget this year that had risks identified in it that were 3 times what our typical might be because there are funding sources that on a daily, weekly basis are being shifted in terms of qualification. Medicaid in particular, many people, when they think of Medicaid, they don't realize the face of Medicaid is truly the face of a child. This is the vast majority of enrollees are children. Now, they are not the vast majority of cost, but stability in that system is what is caring for our children. And it's very true in this state. So half of the care that we deliver at Children's Minnesota is to children who rely upon Medicaid. So disruptions to that are very concerning. What I'm hoping What I'm hoping happens is that we get some stable, we get some communication that helps us understand what are stable funding sources and what are not, so that we can start to plan for and adjust for the realities that are coming. And that's a challenge for all of us.
Just, I really appreciate, Emily, you talking about, our children are on Medicaid. Largely, it is the largest population in the country. Medicaid is also your parents who have spent down their life savings and are encountering health care, and Medicare is not covering it. So we have a large population of older adults in our country that are on Medicaid as they have gone through their life savings and their Medicare. And so you take those together and you say, we know that Medicare, serving largely our older adults, and Medicaid, certainly a disproportion of children, combined represent for Allina Health about 60% of our total reimbursement, if you looked at a pie chart. Those two programs don't cover the cost of care. That's the structural challenges that we face as a field, and it's a bit more significant here in Minnesota because of our aging population. The number of people going into Medicare every day is increasing. It's particularly significant against when you look at workforce, and it was mentioned, I think about our workforce every single day and the shortages that we're facing when you look at healthcare professionals. Now, the good news, I really believe technology is advancing at enough of a pace where over the course of the next decade, hopefully sooner, the next 2 and 3 years, we're going to see dramatic opportunities to serve people differently in different lower cost settings, and ideally, every chance we get, earlier and earlier to keep them well and healthy. So.
Great.
Maybe I'll jump in from our perspective. I guess I'd start with the hope, and the hope is really about finding a path to reinstating the enhanced subsidies in the ACA space. So I'll set that aside a little bit, but there are big implications of that beyond just the individual market. Clearly, it affects a number of people who are no longer going to be able to afford their health care without those enhanced subsidies. But in addition to that, when they drop out of the population, it drives costs up for everyone else. It raises the number of uninsured Americans who are now using emergency departments for their health, usually later than we would like to see them, and so getting the highest cost care possible. And so there are a lot of ripple implications of that. But what I think on the concerning side and what we're watching for is similar to what Lisa and Dr. Chapman talked about, but the implications of some of the legislative changes and the Medicaid changes that are coming in the Big Beautiful Bill. Some of those are starting as soon as 1/1/27, and that will have profound impact on our state and our entire healthcare ecosystem. We talked about the pressure in the market. We know that health systems are under pressure. We know that reimbursement rates are insufficient. I think it's interesting that we've just become accustomed to saying Medicaid covers 60 to 70% of the cost. That shouldn't be the model. That model is unsustainable. We know that health plans, every nonprofit health plan in the state lost money last year and will lose money again this year based on Q3 filings. So there is no place in the state doesn't have the funding. And we talked a little bit about employers. Employer-sponsored plans already pay 2 times the rate for care than Medicare and almost 3 times the rate than Medicaid. So employers are stressed as well. They want to continue to offer health benefits to employees, but that is becoming unsustainable, and that cross-subsidization is unsustainable. So those are pressures that already exist. And then with the implications of the Big Beautiful Bill, with incremental work requirements, validation of those work requirements, incremental validation of eligibility, those layer on an entire layer of administrative burden that our system is not prepared to take on. I've heard it referred to as the largest unfunded mandate in history. So the implications of that, again, go to enrollment and people's ability to maintain their Medicaid coverage. And, we've seen this when we did redetermination. We've seen this when work requirements were implemented in other states. People fall off just because they can't get the paperwork done. And then they're uninsured. And then we start this cycle of uninsured members. Again, where do they get health care? When do they get health care? And who pays for that? We all pay for that. The administrative burden, we know in Minnesota, could be north of $160 million a year, is the estimate from the state, just to implement these requirements at the county level, which is the way we do it today, very antiquated systems at the county level. So that's an opportunity, but it's also a cost. And then overall funding expected to go down by up to $1 billion. And that's just in the bill. That has nothing to do with what's going on right now, where we're talking about $2 billion. So that is, what we have our eye on. I think we have an opportunity. We are very fortunate in Minnesota to have a healthy nonprofit ecosystem that can come together and work on solutions. We can work with each other, we can work with the state, and there are opportunities. We can do things more efficiently. We can find ways to invest in automation and technology solutions to reduce that administrative costs. We need to address fraud. We need to think about reimbursement rates and getting to a more sustainable level. And then we probably need to look at our benefits. And so that is an opportunity we have in front of us to get ahead of this a little bit. I mean, the timeline's very short, and come up with solutions, but that's very hard work. So that's what is on our mind.
If I can just make a comment too, and to put perspective around our Medicaid system, there are over 1 million Minnesotans who rely on fee-for-service Medicaid and managed Medicaid to get access to care. But to zoom out a little bit here, the U.S. is the largest economy in the world, nearly 30 trillion GDP. If you take U.S. healthcare out of our economy, we're still the largest economy in the world, and U.S. healthcare on its own becomes the third largest economy in the entire world. Nearly 20% of that revolves around Medicaid funding. And as Emily and Lisa said, it's not for those in complex socioeconomic positions or low income. It's our children, it's our parents. We need to look at this Medicaid program as highly dependent. It's a huge part of our economy, how people get access to care and how our systems operate and hopefully thrive.
So HR 1, all right, it's as the other panelists have said, the list is long regarding, the $1 trillion reduction in Medicaid support. It's going to happen in gradations over the next several years. The last year has been almost a full-time job to educate our 10 congressional delegation members and their teams about what does it mean in each congressional district. And now trying to understand what HR 1, which rule hits today, which rule hits in a couple of months, which rule hits in 2027, and the implications have been talked about by the other panelists. But to Lisa's point, so 60%, 64% is the average Medicaid plus Medicare covered individuals that most health systems and hospitals in Minnesota serve. In many rural counties and rural hospitals, that's close to 70 to 80%. Now, you could sit there over your muffins and be like, what does this have to do with me at all? Well, it has everything to do with you, because the costs of what the delivery organizations to my right here, what they do and how they provide care, the costs for that are fixed. You got to pay the registered nurses in Minnesota what we pay and what they have built their life around. And repeatedly over the last several years, Minnesota is the highest ranked state in the country for registered nurse pay when adjusted to cost of living. So the highest pay in the country. So can't suddenly start doling out pay cuts to anybody. So you got to support your care teams. And then you have to buy these highly specialized drugs, right? And those drugs, those prices keep going up. And all of those are for-profit vendors that are right there making their profit margin and selling those incredibly expensive pharmaceuticals that our patients need. The electronic health record monopolies take their profit cuts and have massage parlors in their large, expansive offices, while we and our nurses and our leaders, most of us here, are either to be found on hospital floors rounding or in our little cubicles. We don't have the vegan lunches and the massages that some for-profit sharks in the Shark Tank can afford. We are the caregivers that are at the very bottom of this trickle down. So as we think about the federal HR 1 and the implications, and then think 70 to 80% of that reimbursement is not covering the cost of care. Well, go ahead and reduce the cost of care, why don't you, Lisa, Emily, and Todd? Well, how? Those are fixed costs, and they're increasing because there are for-profit players that want to take their cuts. And then there's the acronym soup that I remember down in the basement here talking about last year, and that acronym soup is insane. The PBMs, the PBMs are taking their cuts in the middle of all of this, and the pharmaceutical companies and the electronic health record companies and the IT companies, everybody wants their profit, but at the end of the day, our nurses and our physicians and our social workers and our nursing assistants are taking care of you 24/7 in that very constrained environment. So that is how HR 1 and the implications of Medicaid reductions in support connects with you, because if we have to take care of society and all comers, because we are also legally and ethically obligated to take care of everyone that comes to our emergency department, then we are very constrained, because if our costs are fixed and our reimbursement for the government are going down, how do we provide that care if it's employers, right? It's you all, or it's society. It's very difficult. So that's how HR 1 connects to all of you, and obviously it's deciding what we are able to do right now across our hospitals.
There's been some indication that there are some things that are being done or can be done to try and keep costs from rising so much. Can you kind of dive into that a little bit more? We'll start with Lisa. Shannon?
Yeah, there's often more than one Lisa in the room. Yeah.
Especially in our age bracket.
Yeah, exactly, exactly. It was very popular then. It is, we're an employer just like most of you in this room. And what can we do together, individually and collectively, to really work on making our workforce healthier? So at Allina Health, we really think a lot about, first of all, how do we create the environment where people prioritize well-being? How do we think about ways, whether it's mental health through our provider well-being center, whether it be giving people purpose and meaning in their work. So we spent a lot of time this year on our compass, which is our vision of becoming our community's most trusted health ally, to Emily's point, where all people can access specialty and preventive care where, when, and how they need it. Now, what does that have to do with health? Well, there is something about being mentally well, working for a purpose that's grounded in incredibly meaningful activities in your day. So I would just encourage all of us, are we incentivizing preventive care? are we creating environments where we model as employers, as I know I've coughed a couple times here, so what I would say though is as we model health, as we model well-being, as we create benefit plans that incentivize prevention and work with payers like in Lisa's shop and others, I do think as a community we have to face the reality that the hospital doors are the only doors open 24 hours a day, 7 days a week. There are no other doors that are open. We must keep ourselves strong and healthy and available and accessible to our community, and that's going to require partnerships. It's going to require our public, our elected officials. It's going to require private, such as philanthropy and other support that we're so grateful for those that invest in programs that our community otherwise wouldn't have. And it's going to require us. So this public-private and philanthropic partnerships, it's going to require employers who are also advocating to say, we have to do some things differently. I think it structurally comes down to a business model. Look, I'm a mother of 4, and I want my kids to afford health care. They can't afford health care. That's not okay. And we want to make sure that we create a system that becomes sustainable, and no one of us can have that answer by ourselves. So I don't want anybody leaving here today saying we're in real trouble, and we have real needs to come together differently, to use technology differently, to work through a change of the reality that our hospitals and health systems, which I can speak to best, can't be public health for our communities. We are absolutely committed to playing our part, and we care deeply. I want every member of our community to have access, ideally before it requires the emergency department. So I look to how we do it together and getting earlier upstream so we can really prevent the spend.
I would echo what you've said and also say that we need to fundamentally rethink, eventually we will be forced to fundamentally rethink where care is what care is delivered where, and how we do that as a collective rather than as a fragmented industry. And that includes things like how do folks in the metro area support the delivery of specialized care in the rural community? How do we work together to do that? How do we be a teleresuscitation where when a newborn is delivered in a rural hospital that does not have maternal care because they can't afford it, they can't staff it, how do we ensure that we have expertise that can be in that delivery room virtually, resuscitate that infant, and bring that infant to the care that they need? And so this is a particular problem for our state, how much fragmentation we have in our industry. But I think it's something that we need to recognize nationally, that this somehow we have got to shift this to where this is a cooperation rather than a traditional business model of competition.
Yeah, I think it's a question. It's a question that I've wrestled with since I stepped into the role. There are the things that we do every day to help manage cost, and that really is one of the roles that a health plan plays is, working with members, working with providers to try to prevent some of the things that are preventable. How do we get ahead of emergency room utilization and ensure the right care in the right setting at the right cost? How do we work with our drug formularies to help manage the drug prices and the inflation there? And I do think technology will play a big role in helping us do that better. But ultimately, we have some underlying foundational things that are driving costs. It's the aging population. It is the health of our population. It's the increase in chronic disease. And so some of the things that we talked about, how do we create an environment of wellness and support that? And that really gets to our belief and what I think we need to do longer term, that partnership with providers, the integration, creating a seamless experience for members where they feel like they have options and choices. We're providing them with options to have better health, to stay healthier, early on and stay on that healthy path. I think long-term, that is our opportunity to bend the cost curve, because none of that unit cost optimization, while we need to do it, and it's important, it isn't going to solve this challenge. And so I think that structural piece that Lisa talked about so well, like the structure, this business model is broken, we need to address that. And then how do we focus on that partnership that allows us to have members feel cared for and feel like they are engaged in making better choices for their health?
Shannon.
I maybe want to offer a couple examples, because you can sit in this and say, how do we get through this and how do we get through it together? And on the earlier detection and curative side that Dr. Chapman talked about, the innovations. Now, structurally, we do have a business model and ethical dilemma. How do we afford GLP-1s as an employer? How do we afford all these new technologies? But the practical reality is, I'll give you a couple examples. So lung cancer screening. We now have AI-enabled technology that assists our professionals, our radiologists who are exquisitely trained and yet can catch cancers before the human eye could see them. Last year at Allina Health, we caught almost 300 more cancers in stage 1 from that in lung cancer. We have the ability, every CT scanner now throughout our system has technology that can detect stroke. What does that look like? That looks like an 18-year-old who fainted, who comes into freestanding emergency department, who the technology, before the radiologist could even get to the image, paged someone that this young woman was having a stroke. The treatment could begin and transferred, and she walked out of Abbott Northwestern's emergency department. We are doing, as a community, amazing things in healthcare as an industry and field. So I want us to have the sense of possibility along with the reality. What are we trying to protect here? Those are the things that we're trying to protect. We're trying to invest in these new technologies. And I do think there are things on the horizon we'd all agree with, that whether it's AI or other tools that are going to keep our families healthier, we still need the partnership to find a different way forward.
Great.
And we can do all of that, and we are not vaccinating our children. We're not using technology that has been in place for decades and proven to ensure that our length of life is markedly different than it was before. It is astounding to me that we are embracing things that are so novel, so innovative, so new to the field, and at the same time we are not preventing childhood disease. So we have got to embrace all of it.
Well said.
I want to shift now to the next question, and I shift a little bit to leadership. You're all CEOs. You all lead workforces that range from hundreds to tens of thousands. As CEO, how are you approaching your role as an employer, and I might add, long-term and in this current environment? Let's see. We'll start with Lisa Shannon.
You know, everyone in this room leads something. And I always say our job as leaders is it works really well when you love what you do. And you can more authentically give people hope when you really believe in what you're doing. I think healthcare is one of the greatest fields that I could have spent my whole career working in. And that's what I have done and what I intend to do. I do think it comes down, though, to particularly at a time like this. So we haven't talked about some of the other, Dr. Chapman mentioned, you know, people who are afraid in our community right now. And I think that looks like a lot of listening and validating the feelings that people have. I think it looks like reminding people what our role is and how important it is that we serve our communities. We have quite a privilege to take care of people during their most vulnerable times. It looks like we remind them of our policies, procedures, we support them, we have people they can call. What it can't look like right now, and this is the hard part for me as a leader, is we can't reassure people. I can't tell you it won't get worse. But what I can tell you is that our role and the role we play, and with clarity of our compass and our vision and our values, those things are unchanged. And so as a leader, I think about what can we assure people of that won't change as they're facing a lot of noise and change around them, and that listening from the perspective of validating how people are feeling right now, while staying laser focused on the part we have to play in the community, which is frankly quite an awesome role that we get to play, that we're so grateful to the community to trust us with.
I would add that we also have an opportunity to help people see that in the face of challenges that are ongoing right now and disruptions and traumatic events, we have seen incredible beauty. And we have seen people join together, hold hands, face things, comfort one another through various challenges, helping our workforce see what has emerged within and from this challenge, this obstacle that we are facing. Name your obstacle. It's a little bit, that's an important part of being a leader in healthcare right now.
Yeah, I'll just make a quick comment. I mean, in the mental health care space, when, as we have conversations about affordability and expenses, in mental health care, all we have is people. And that's great. That is truly our biggest asset. We don't have things. 70% of our budget is salaries and wages. It's about building trust with our team members, nourishing relationships. In one of our clinics, we have a centrifuge that I think the past tenant left behind if somebody wants it. We don't know what to do with it. We don't have equipment. We have pretty cool technology. Do you want it? It's yours. I'm afraid somebody's going to try to use it and it'll cause problems. So as a leader, we spend a lot of time creating trust, creating safety, building those relationships, doing everything we can to get people engaged in our mission. And I think to the point of my colleagues here as well, one thing I'm working on as a leader is being direct, being honest about the challenges we're facing. People need to know that. I've been accused of being Pollyannish at times as I'm making intense eye contact with my colleagues here at PrairieCare in Newport. And we need to help them join us in breaking down these barriers and these challenges and really empower our workforce to tackle these forces head on with us.
Yeah, I guess, can I just add a quick comment? I think everyone on the panel covered it really well. We also are in the people business, and it's been a challenging industry to be in from a payer standpoint. The press is not positive. It's easy to, cast blame on health plans and payers for some of the things that people are experiencing in the healthcare market. One of the things I was really struck by as I came to Medica was how mission-driven the organization is. People are there to serve members. Our mission is about caring for our members in the moments that matter. And so, really focusing on how do we bring that mission to life? How do we build a culture around that is focused on our members, collaboration, delivering results for them, and continue to keep the mission at the middle, because it's hard to go out when you spend a day working hard and then you hear some of the comments that come out in articles or in press releases. It's challenging for our teams, and so that's really a focus for us is, how do we stay mission focused? How do we keep people really working towards that goal and embed that into our culture?
Thank you. We'll go to audience questions in a minute. I just want to maybe talk about your employees and your health plans. Lisa Erickson, what are you seeing in trends for health plans and their employees, and what are the most notable trends?
Good question. There's two parts to that. Our own health plan, so for our employees, we really feel like our benefits should reflect that mission that I talked about and that goal of creating an environment where they can get the care up front and the wellness that will prevent further health issues down the road. So what we've invested in this last year is really enhancing our preventative care, coverage, enhancing our mental health options and coverage, free mental health visits, guaranteed access within 48 hours, and using our employee plan as a way to kind of pilot things that we think would be valuable for the rest of the population. What we're hearing from employers that we work with is cost, affordability is high on people's minds. Obviously, employers want to continue to offer health benefits. They care deeply about the health of their population, but the costs and the unpredictability are challenging. So they're also looking for value. How do we, and willing to invest in programs that add value, that improve health, that allow and assist members in finding the highest quality care at the lowest cost. And so those are the things that we're really hearing from our employers.
I'll just add that, healthcare, and I remember saying this last year too, and maybe some of you or your loved ones, chose healthcare or at least decided to look at healthcare as a sector to work in. But to Lisa's point, healthcare, the pay is good, the job is amazing, having done it now for 25 years plus, and we still have tens of thousands of positions open. Now, that's the challenge, but the good news, talking about our workforce in healthcare, is that with the 24/7 work of the three on my right and their teams, it's not just HR or leaders, it's everybody promoting a career in healthcare. We have seen improvements in our recruitment numbers and retention numbers. So that's great. There are more nurses coming back to the bedside, which is great. Having said that, though, there's still open positions. So I'm going to have another call to action for all of you. If you have a neighbor, if you have a child, if you have a friend who's in another job but is looking to switch, check out healthcare. Check out healthcare. It's an amazing team-based environment. If you do AI, we do that. If you do hands-on service, we do that. If you do security, we do that. If you want to just join a dynamic team and serve people. So with the leadership of my board at the Hospital Association, we are launching our very first virtual career day that we've been planning the entire last year. And it's going to be on February 12th. And the organizations, Allina and Children's, are going to be participating in that amongst many other hospitals. So we'll have leaders in this 3-hour virtual career day showcasing the different departments and places to work inside a hospital. If you want to know more about it, come see Luann. Raise your hand, Luann. We have a virtual a QR code for you to check it out. Please spread the word and have your neighbors, have your kids, have your friends, come check us out. We need every human to think about healthcare because we need you. And by the way, it's a fun place to work.
Great, thank you. What questions do you have? So raise your hand, and we have some people wandering around with microphones. No questions right now. Oh, there's one right back there.
I had a question. You had thanks for the panel, first of all. You talked a lot about future plans, or you mentioned a 5-year plan. Kind of in the news and trending now is the idea of lower population. We have less children, even though they're very vulnerable right now, but we're aging population with less children. So looking at the crystal ball in 10 years as the workforce has gone out, and we're really focusing in as the children coming in are growing to become the workforce, and then there's less of them. How does that look in healthcare and serving the community?
I will say one of the challenges that we have is as we rush to fill the workforce gap, we have appropriately, as an industry, tried to tried to be more efficient with training, orientation, and getting people into roles more quickly. that also means that there is less and less exposure to some of our work environments. We're finding that people are not spending time in a pediatric operating room as part of their nurse training, so they don't fall in love with that and commit their lives to it. So I think one of the important things as we who are doing healthcare delivery now is to ensure that we open up our doors to help people see what a life caring for others can look like and how dynamic different aspects of healthcare can feel. So we know we're going to need to compete against other opportunities for that shrinking workforce as a country. So that's an important part of it. And then looking at how we deliver care as efficiently as possible, whether it's technological solutions that support our human beings and make the best use of our human beings, or whether it's thinking differently about what a care team looks like in the future. All of these are parts of our plan.
Yeah. Other questions?
I mean, I would say, I think over the next 10 years, the impact of technology and AI on how healthcare is delivered is going to be exponential. I think we're just dipping our toe, and I'm sure all of you feel the same way. We're just at the very beginning.
Thank you all. It's been a wonderful panel and very insightful. And if I may, this is for Lisa Erickson, if I may take you back to your experience in the PBM industry with this question. And, drug costs are a challenge. I can attest to that. And do you ever think we could get to a marketplace that is net price driven without rebates?
Absolutely.
And how so?
Yes. There's a lot of structural barriers to that, and some of it is, there is a misconception, I believe, about rebates, that, first of all, that they're being retained. 98% or more of rebates are passed through to the client or to the government. So that's the first thing. Second is rebates are very, it's hit or miss. What therapeutic classes have rebates? So if the goal is lowest net cost, pass the rebates directly through to the consumer, you will have winners and losers. And those winners and losers don't always make sense. So there are a huge host of diabetes drugs on the market, and they're very comparable, and you can choose between them. And so it's highly competitive and highly rebated. But oncology and HIV traditionally have not. And so you will end up with people who, yes, pay very low cost for their drugs, but then you have another group that would be paying really pretty astronomical prices. So there are pluses and minuses to passing rebates through to the end consumer versus how they are often used by employers today is to lower the overall premium and the overall cost of health benefits. So I think there's a lot of nuance in that space that doesn't get talked about when we kind of hear the headlines on PBMs. But I do think there's an option to get to lowest net cost. One of the things that is going to drive us there is the introduction of biosimilars specifically is a great example. In the biologic space, that's the Humira, Stelara, those types of drugs that are very high cost, traditionally have been some of the highest spend. That was before GLP-1s, but highest spend. The biosimilars are coming out and radically changing that, and their starting point is a lowest net cost model. So I do think there's certainly opportunity for that. There's disruption to get there because this is a structure that's been in place for a long time. There's things we hear about Mark Cuban, cost plus model. That's great. Most of that is generics, and generics did have a margin, but brands are priced underwater. So there's things that would have to reset in this market for it to all go to net cost, cost plus type model. It's the direction that I think everyone's going, but it won't be without some bumps.
Hello, my name is Rachel Kashani Legler. I'm the Dental Hygiene Department Chair at Normandale Community College, and I'm here with some colleagues from the college, from our Health Science Division, as well as our foundation, and we are currently building an interprofessional education simulation center at the community college at Normandale. And our hopes are, more student recruitment, a very qualified workforce, better patient outcomes. My question, as someone who has been in the dental profession for a couple decades, is I love what I'm hearing here in terms of healthcare, and I love that mental health is up here, but often you don't hear a lot about oral health, and I know that's just the way our systems have been built and segregated over time in terms of oral health care, overall health care, even the coverage that we have for those. So my question, and I know this is a loaded question, but as we have this new simulation center for interprofessional care that's being built, and we're working on curriculum and how we can bring our programs and professions together at Normandale Community College, how do you currently utilize the dental profession in your organizations and or companies, and or how do you see oral health being more a part of your organizations in the future?
Yeah, well, I love the question. The person you're going to want to talk to is Allina Health's Chief Operating Officer, Medica, who was a dental hygienist. So I'll give a plug there. What I would say is think about the way we, and I know I can speak for all of us here, we think about the whole of a person, whole person health. And so to have whole person health, that includes mind, body, spirit, and in that body, of course, is our dental care and oral health broadly. So we continue to have great partnerships. I wonder, Dr. Chapman, if there's anything you want to add. Certainly oral health early on in the care of our kids, and for all of us, really quite important. So while it perhaps is delivered through partnerships that we have with the dental community, and no one of us does everything by ourselves. And so we would be always open to a number of partnerships that look at the whole person.
I think we learned from our mistakes with the concept that somehow there's physical body health and there's mental health, and that took us down a path of just disastrous, sort of in terms of how we built our care. I'm hoping that we will address this in the same way. Pediatric dental health, of course, is critically important. That said, dental health is life-threatening in the elderly, routinely. And we have yet to kind of put that together and realize that the sepsis, bacterial infection in the bloodstream, is coming from the fact that we have pretended that somehow teeth and oral health don't matter. So I hope we can correct that.
Another audience member asked the panel if they saw a time in which the cost curve would start to bend down again, or if there were any steps that employers or providers could take now to help curb healthcare costs.
Yeah, I think that, we talked a little bit about what employers are looking for, and one of them is innovation in the space that helps them manage costs. And so, there are places, I think technology will be a big part of that. I think really getting deeper and understanding populations and being able to get into kind of predictive analytics that help us get ahead of things with employers. We're doing that in partnership with some of the provider systems that we work very closely with that allows us to get ahead of medical emergencies or disease and treat it differently. One of the things that's been very popular is, how do you steer employees into high-quality, lower-cost providers to ensure that you're getting quality care at the lowest possible cost. I think the other place I would say is really important is mental health. That's becoming more and more of a focus area as everybody's recognizing that as a key part of your health overall. And so I think employers continue to look for that. I don't have the magic bullet answer on what's next. I feel very strongly in the role that technology will play, the role that advanced analytics will play in helping us, and then, again, longer term. And we have a lot of clients who are long-tenured employees, and that does give us a chance to think longer term about, again, how do you work up front to help people have a healthier, engage in their health in a different way. And I think employers that have long-tenured employees are interested in that as well.
Just first wanted to say thank you for advocating for our communities here and all the work that you're doing today. My question is around, I think we can all appreciate the importance of preventative and proactive healthcare. And I'm curious what your perspectives are on gene therapy and maybe what your organizations are doing to invest in those sectors currently.
I'll start with that. This is part of that, what's possible, that it truly is possible to prevent a disease before it ever starts, and certainly to treat it rapidly when it does start and is recognized. And the ability to personalize that cure is spectacular. To get there is going to be complicated, as I gather you know from the way you phrased your question. One thing that's very important, and I think those of us who are in care delivery, is we need a better connection to bring our patient population to those folks who are developing those emerging therapeutics. And so I encourage us to work together, whether it's pharma, med tech, what have you, academic institutions, to bring those to the patient populations. I have in my emergency department alone, or our 90,000 children walk through these doors. Let's learn from them, and let's make sure that those kids who need therapies get connected to you all. But that's going to take a different way of networking and a breakdown in the silos in our industry. So researchers, developers, pharma, medtech, connecting with our patient populations in order to bring those to fruition. And then the other thing we have to do is we're going to have to simplify the accreditation processes that allow us to deliver those medications in our different institutions. And we're going to make sure that we can respond quickly to how rapidly this is advancing so that the reimbursement is in place to sustain the development of these.
Yeah, I would just add to that, I love the question, and what we're going to know about the human genome is, you can't even wrap your head around it right now. It is going to be completely breakthrough. We're going to have to do this at national and international scale, not just by ourselves. And so, frankly, I would add that I think a lot of our problems are going to have to be solved at a more national scale, not just here in our community.
From one other perspective on that question, the potential for curative options is incredible, and people are excited about that. But how you pay for that is really challenging. And so if you think about an employer, especially smaller employers, these are very rare diseases. Your chances of having someone in your employee base or a child or a dependent is low. But if you do, it can be catastrophic for a small employer. And so figuring out what our mechanism is to pay for that, and that might be a place where there's risk sharing, there are reinsurance type programs. There's a lot of things being considered, but that is a place that needs more development in order for it to actually be really exciting, because I think there are a lot of employers that are really nervous about the idea of covering that and what the implications could be for them.
Great. Next question.
Hi, I'm Anjali Cameron. I'm CEO of SIWA AIFW. So my question really focuses on this new growth within the market. I think there's a fragmentation in the healthcare system with more direct-to-consumer, with the growth of direct-to-consumer industry, with brands like Better, with in mental health, or we've seen a lot of growth within GLP-1 and the Trump RX system. So within that, it's upending traditional healthcare models. It can be cash-based, it's consumer retail, and it runs the risk of also preventing high-risk patients from entering into the traditional healthcare system. And so how do you anticipate this shift within the market, this fragmentation within the market, and how are you anticipating adjusting your models as this industry continues to grow?
Go ahead.
Yeah, I love the question around, there are a lot of niche players in healthcare and that are uncovering new ways of delivering care. And I think we need all of them. I think we as a healthcare delivery system, I'll speak for Allina Health, are looking for ways to partner with them. We don't think we have to create everything by ourselves. And we think answers are going to come from the partnerships that we form. We have a number of them today where we have partners, many around this table are partners of ours that we're so proud to work with. And the key is, for a patient, how does that partnership stay seamless? Because as a patient, you want to know that the care journey isn't as fragmented, and that's partly in your electronic health record, it's partly in data exchange, it's partly interoperability, which is a big priority of many of us and certainly the administration. And so I would just encourage and share with all of you that our desire is to build a better, more trusted, more accessible healthcare delivery system, but not all by ourselves.
I think that's probably similar on the payer side is learning, watching, learning from the ones that are really working. Is there a way that we can learn and incorporate the things that are working into how we offer benefits to our clients and our members? But I'm also fascinated by some of the developments in the off-benefit, direct-to-consumer space. And I think GLP-1s is a great example where, that has been cost prohibitive for most employers to offer for weight loss. And that off-benefit kind of direct-to-consumer market is really dynamic. And so I think watching that over the next few months and year and see where that goes will provide a lot of learnings. And maybe there is a really positive opportunity for on-benefit things that are included in your health plan and off-benefit that is more competitive, market-based.
I think I heard in part of that question was, brand awareness and direct-to-consumer marketing and so forth. In mental health, it's about awareness, it's about access to care. And, this is a rhetorical question, but, think to yourself, name 5 hospitals in Minnesota. You can probably figure that out. Name 5 mental health hospitals in Minnesota. It's a trick question. There's only 2 of them. But nonetheless, think to yourself, where are those mental health resources? There are so many barriers in accessing care, and one of them being stigma, one of them being the pervasive stigma, the fear of discrimination. If I reach out, if I'm asking about these services, what will people think? So we are trying to normalize access to mental health care, just like across the spectrum of all areas of health, oral, and so on and so forth. We want to make sure that people know where we are, that we break down those barriers, and that people feel safe asking for help.
Parents on Medicare, how do caregivers factor into the ecosystem, and what role do you see them playing, and how can we support those caregivers?
And let's clarify the term. When you say caregiver, you mean?
I'm thinking of somebody like myself, sandwich generation, kiddos.
Parent, yes.
Parent in-law.
I'm just clarifying.
Thank you.
Yeah, absolutely. I would like to say it's one of the things I think we are getting a much better handle on in pediatrics. We've had the opportunity to, before the rest of the healthcare system, I think, to incorporate parents into the care model. And one example is the concept of inpatient mental health, where a parent can stay and room in, which is very different than you might think of otherwise. I think one of the difficulties is taking a workforce who does something repetitively day after day after day, years and years of learning and experience, and somehow help them see that their very best source of information and their most effective tool in returning, in my case, a child to health, is standing right beside that child. And so that's a culture of how we orient around the fact that that parent is that. people differentiate when they go into pediatrics or when they run like hell from pediatrics. It is typically because they either are fascinated by and in awe of the power of that caregiver relationship with their patient and what it's capable of doing, or they see it as complex and messy and a pain. But so really leaning into that. I thank you for calling it out because I think it remains in our healthcare system untapped to the extent that it ought to be.
You know, on the other end of the spectrum is a geriatrician like myself, and we're doing, innovations very similar to that. First comes empathy at the load that caregivers carry when it comes to elder, and older adults. So understanding that and making sure that the caregiver is part of the team, like Emily said, and then using technology, smart rooms, apps, and all of the things, the Internet of Things, if you will, to support that, older adult, that patient, any age. Because, the caregivers are carrying a burden and need to feel that they're part of the care team and a very, very essential part. So we've done that in geriatrics and in adult medicine, just like, in pediatrics too. And there are innovations that are supporting and uplifting that even more.
All right, thank you very much. That's all the time we have. So let's give our incredible panel of healthcare leaders a big round of applause.
Again, that's Dirk DeYoung, Editor-in-Chief at the Minneapolis St. Paul Business Journal. I'm Tim Nelson, and you've been listening to Hospital Matters from the Minnesota Hospital Association. Join us next time for another look at issues impacting hospitals, health systems, and patient care in Minnesota. Thanks for listening.